Hello, everybody. Today, I'm going to be talking with Kristin Raj. Dr. Raj is a good friend of mine, and we've worked together for quite some time. And as a way of background, she's a pretty impressive person. So just in a lot of ways. So first off, thank you for coming on and agreeing to talk.
Yeah, I'm excited to do it with you.
So by way of titles, she is a clinical assistant professor at Stanford's Department of Psychiatry. And she's also one of the psychiatrists who works on the ECT and the TMS services. She's the co-chief of the mood disorders section, and she's the director of education for interventional psychiatry, which is a new and exciting term. And why don't we start the discussion off with that? Like, what is interventional psychiatry, broadly speaking?
Yeah, interventional psychiatry is kind of an umbrella term to include TMS, so transcranial magnetic stimulation, ECT or electroconvulsive therapy, and typically more rare treatments like deep brain stimulation, vagus nerve stimulation, which are treatments for treatment-resistant depression. Those that umbrella too. And some people will also include ketamine infusions under interventional psychiatry.
So you're a smart person. Tell us about your journey. Why, of all the things that you could possibly do in psychiatry, why this? There's a lot of cool things to do in psychiatry. Why do you want to like zap people's brains with magnetism and electricity and stuff like that? What's up with that?
Yeah, great question. It's actually something I didn't even know about until I was a fourth year resident. And we had the opportunity to have an elective rotating on our ECT service, and I did that. And that's where I first learned about ECT and learned about TMS a little bit after that. And to me, once I learned about it, it really struck me that psychiatry is a combination of multiple treatment positions. Psychiatry is psychotherapy, and psychiatry is these interventions. And so my practice is to have some of all of those things. And it's really meaningful to me to know all about psychopharm, to know about psychotherapy, and to know about ECT and TMS, and to be able to do each of those things so that when I think about a patient, I can think about which modality is really the right fit for that person.
When you're on that fourth year rotation, or maybe since then, for a lot of people, there's like that one patient where it's like, oh wow, this stuff really works. Is there any patient experience that made you think like, wow, ECT is real, or that I want to do more of this, as opposed to what most psychiatrists do is like, it's some combination of meds and therapy, but mostly meds, let's be real. Why did you want to not go that traditional route in what your clinical practice looked like?
Yeah, I would say that the most profound times that I've seen someone's depression improve have been with ECT. So we'll have someone who is inpatient, and I know their history that they've tried multiple medications. They've been depressed for a year or more, and they've tried another medication inpatient. They haven't changed. They've been on the inpatient service for a month and nothing's touched anything with their depression. And then I've seen over the course of a few weeks of ECT, this person who looked like they were going to be depressed and nothing was going to help them, to then see them start to brighten, and that they start to describe feeling better. And then that change at the end of ECT where they say like, wow, like, I'm really glad that I did this. Like, this is a really noticeable. Have their family members really notice it, their whole team notice it. That sort of transformation is something I've particularly experienced with ECT, and it's really meaningful to be a psychiatrist in those scenarios.
Yeah, no, I mean, I remember when I was saying with me when I was, I think this was my second year when I was at Stanford in the inpatient, and it's just so one of our patients, I wasn't on the ECT service, but sent the patient off to the ECT service, and like they've just like there was just like that resting, like the face was just so clearly depressed, and like, and then like the next day it's like even at like it's this transformation, and like you never see with medication and rarely with therapy, but like the word you used, and I like this metaphor, was brightened. The face brightened. It was like, whoa, this is something. This is something profound. Something happened with that treatment that unfortunately doesn't happen all that often with a gradual change in medication. Did it work? Did it not work? Well, let's do this carefully designed study to check. It's like no, that just worked. That was different. Nothing's changed for 20 years in some cases, and now it's different today as opposed to yesterday. I mean, it's pretty cool.
Yeah, absolutely. And I don't know what it is, if it's maybe the timeline of ECT or the fact that someone's tried so many other treatments and they haven't worked. And so then to see something like profoundly work for a patient is really powerful.
Yeah. No, I totally agree. So let's talk a little bit about the treatment itself. Like what is it fundamentally when we talk about ECT as a treatment? What are we talking about? What sorts of what's the technology involved, and why did we ever have the idea to do this in the first place? It seems kind of crazy, kind of barbaric.
Yeah, I mean, it does seem kind of crazy. It started off where people sort of just found that through inducing a seizure. So they first did it through like insulin and would have a seizure, and they noticed a difference in their mood afterwards. And then they tried electricity. This is maybe back in the 1930s. Tried electricity then to induce the seizure, and found that these patients who were either like profoundly psychotic or profoundly depressed, there was a change after they had that seizure that was induced. And so there is something mechanistically about inducing a seizure for someone. So not order, but where we're kind of exogenously, or like we're giving them something to create the seizure. And so currently that's through electricity is how we do it. And there's something about that. No one really knows the full mechanism of why that works. But once that happens, and then over a period of time of treatments, usually around 10 or 12 of those treatments, typically people will remit for their depression. Yeah, so it's electricity inducing a seizure. And then people, like initially, I think the ECT got kind of a bad rap, and for good reasons, because anesthesia wasn't used back then. Anesthetics weren't even commonplace back in the 30s. And so then once like muscle relaxants and anesthesia got to be more commonly used through the 50s and 60s, then throughout time, and then definitely anesthesia is widely used. And so it's a very different procedure than it used to be back when like one flew over the cuckoo's nest, I think is how most people are introduced to ECT. And it looks extremely different now, fortunately.
Yeah, no, I think that's exactly. It's a great film. One of the greatest films. But yeah,
it's a really important film, and it took place in work at the Menlo Park VA, so a little local history.
Yeah, one of my supervisors talked about there was some nurse. It was a Nurse Ratched was a composite of several nurses, and
at
like
the VA.
At the VA, and he worked with them. He says, "Yeah, it's like spot on." I was like, "Oh my gosh." Oh, she's terrifying. But yeah, no, not what you normally get at Stanford these days. So yeah, I guess that's so one of the things that's different about ECT, you said, was okay. So anesthesia. Why do you give anesthesia? And sort of what is the experience of ECT if you're a patient? You wake up in the morning. Today's your first session of ECT. What should you expect?
Yeah, that's a great question. So they won't have eaten since the night before, because anytime you get anesthesia, they want you to not eat in case for any reason you'd need to be intubated. And so they'd be fasting overnight. Come in usually pretty early in the morning because we do at least at Stanford, we do all our cases first thing in the morning. And come into whatever the area is for the procedure for ECT. So it's at different places in different hospitals. And the preparation for it is that there will be a nurse there that would help them get situated. The anesthesiologist would come check in with them, and we would check in with them. And then the anesthesia is general, and so they would they get the anesthesia through an IV and would be completely asleep for the whole procedure. And they're we'd give them a muscle relaxant too, and so their body's completely relaxed. Physical seizing through their body because of the muscle relaxant too. What else? And then, so once they're relaxed and under anesthesia, then they get the ECT, and that whole time period for under which they're anesthesia is only about like 5 to 10 minutes at the most. And then once they wake up from that, then it takes a little bit of time to just reorient after the anesthesia. For that, then they're ready to go home. What was I going to say about the anesthesia? Because they're only asleep for maybe 5 or 10 minutes, they don't get intubated. We just bag mask them. And so the anesthesiologist, after they're asleep, will put oxygen over their face and just help them breathe through that. And they don't even need a tube in their mouth or throat or anything like that. It's a pretty fast procedure.
Okay, so from the patient perspective, a nice get to hang out with nice people, talk through the things, get put under, and then you wake up, and then any what sorts of day of effects might a person expect? Yeah,
that's a good question. From the combination of like having had a seizure that day and from the people just don't drive that day, take it easy. Some people just feel a little bit tired the rest of that day. Some people feel totally fine and they can go about normal business throughout the day. But most people, we say, take the day off and be able to relax. Some people get a little bit of headache or muscle aches or nausea, but in the procedure room, we're able to give them medications that can usually be helpful with that. So give them Tylenol or Zofran for the nausea, and if those things come up, we can give them things to treat that. That's usually about it, though.
Okay. How about is this the same thing that's been happening? I mean, this is kind of when you say that we've been doing this since like the 30s. That's not usually high praise for a medical treatment. But have there been any changes with ECT since then? Have we learned anything since then? Do we do anything differently now than we did in the olden days?
Yes, we do. So a major issue with ECT in the past had been memory loss. And I think that still concerns people quite a bit about it, and for good reason. Like, memory loss is a potential risk, but not to the degree that it was, say, back in the 30s, 40s, 50s, 60s, 70s, 80s, because a newer type of ECT since then. And that all depends on where we place the electrodes through which the electricity is delivered. And so it used to be where we'd place the electrodes just on both temples. And for some reason, probably related to where your brain's speech areas are, right under your temples, that tends, and where your hippocampus is on each side, that tends to be associated with a little bit higher risk of memory loss versus a type of ECT that we do called right unilateral, where one electrode is still placed here and then one is placed on the top of the head on the right side. And that's associated with far lower incidence of long-term memory side effects with it. That was developed, maybe I'm going to missay this, but I think it was around the 90s where it got to be more popular.
And so, like, how of the patients that you treat, how many of them end up having any kind of serious memory problems?
We'll say that again. How, what then?
What percentage of
Oh,
patients
what percentage?
ended up with serious memory problems? Like, I think the things that people are terrified of, I don't know if there was one of the premises of the popular book, Zen and the Art of Motorcycle Maintenance, was the guy forgot who he was. And he had to sort of because of ECT. And it's like, oh gosh, that's terrifying. Like, you completely lose all memory of your past identity and have to or like forgetting your wedding or your child's birth or something. Like, I think those are the sorts of things that people are, most afraid of. How often does that kind of thing happen nowadays?
I've never seen it happen. And like where someone has forgotten a major event or lost a sense of who they were, I've never seen it happen. I'm not sure I would still do ECT if I saw something like that happen. The likelihood of that sort of memory loss is incredibly low, even if someone gets bilateral ECT. The more common thing is that a good proportion of people, so maybe half or more of people, will have some sort of memory issue where the day that they get ECT, they might find it hard to create memories that day. Memory loss, where it's hard to form new memories right around the time they get the treatment. And so I tell all patients, I think it's really important for people to know that up front so that they realize, like, okay, it's going to be normal if, I'm not going to fully remember this treatment perfectly well, or if I'm in the hospital while I'm getting ECT, maybe I'm not going to remember this hospital stay in a crystal clear way. Sometimes people will diary more or journal more if there are things that they want to remember during that time. And if they know that, oftentimes people say, I'm not really keen on remembering this time period of my life anyway. Like, that's fine with me if it's not the most crystal clear memory that I have. More often than not, that's what people say. So that's not uncommon, anterograde memory loss. And once people start to space out their ECT or get it less often or stop getting ECT, that goes away. So it's really about the time of like having the seizure that it's hard to form new memories. And then they start reforming new memories totally normally afterwards. A smaller percentage of people, much smaller with right unilateral ECT, but also smaller now with bilateral ECT based on the type of waveform of electricity that we do. So a smaller number of those people will have retrograde memory loss, where they lose some memories from their past. Typically, they're like pretty minute memories. They're not, I've never seen it be a major life event like birth of a child or their wedding or anything like that. It's usually memories that aren't so ingrained. So memories of your wedding, that memory is connected to so many different thoughts in your head, right? Like you hear a certain song and you're reminded of your wedding. You see a certain flower and you remember your bouquet. You see your aunt and you remember how she was at your wedding. There's so many things linking that. The sort of memories that are more fragile are the ones that aren't linked to any thoughts. And so those sorts of memories from the past are a little bit more at risk. When they've done testing, so if you look at studies with memory loss and ECT, with right unilateral ECT, not a lot of memory loss shows up on those tests because it tends to be like some like small little personal details from the past. Maybe you're remembering someone's name that you come across on the street and you're like, I know this person, but it's a little bit hard to remember their name. Things like that we'll sometimes forget with ECT. It's hard to predict who that will be for. But overall, I really counsel people that if possible, try to ask about right unilateral ECT before bilateral, just because your risks will be much lower with it.
Okay, now that seems that seems much better than the very good for dramatic storytelling, very bad for the individual person sorts of sorts of experiences.
Yes, I agree.
Okay, so this is for thinking about what sorts of people might benefit from ECT. I mean, like, for some, and I'd love to hear your perspective on this. I mean, like for some, ECT is like the last resort. Like, I've had people, some of my patients have gone like into the 30s and 40s in terms of number of medication trials, trying to avoid ECT and like going through all sorts of, all sorts of things. Like and then I've heard other people say like, especially people who do ECT, like, I want like one or two medicines and then ECT me. For you, when you think about like, given the risks and benefits, given what you've seen, where should ECT fall, or if it were you or someone you cared about, where should ECT fall on this treatment pathway?
Yeah, when I think about it, it's not a totally linear idea. So the things that I think about before that are how severe is the depression? And so the more severe the depression, that little higher that ECT is going to go on my pathway of how to try it. So say someone was suicidal and inpatient, that's going to bump up a little bit faster for me before trying another medication, just because ECT works much more quickly than meds do. So a medication can take 4 to 6 weeks for max effect, versus with ECT, after a couple sessions of ECT, sometimes people's suicidality will get better. So severity, if someone has some psychosis associated with their depression, that bumps ECT a little bit faster for me. And then length of their depression. Likelihood of getting undepressed is higher the shorter episode is. And so I think you bring up earlier point where if someone's tried so many medications, we know from studies that once someone's tried their 4th medication, the likelihood that it's going to work after they've tried 3 that haven't worked is around 10% or so, versus the likelihood that ECT is going to work in that situation is more around like 50 to 60%. And so I usually post people with those numbers and say, it's a risk benefit ratio for you of how important is it for you to get well quickly? How are you weighing out the side effects that you've had with medications versus the potential side effects with ECT? How have those affected you? And what's the risk to you of staying depressed longer versus what's the risk of ECT timeline of that for people? And so on average, say someone's outpatient, they don't need to be inpatient for their depression. I'd say like around the 4th medication or so, if someone's not having a psychotic depression, around there is where I'd say, okay, maybe do you want to try ECT at this point?
Yeah, and I think this is something that we as psychiatry haven't, and maybe this is partly because our treatments are mostly slow up until, ECT was the exception, but yeah, that it's there's really nothing we could do faster. And so it's like, oh, well, I'll try another medicine for another 8 weeks or whatever. And it's like, okay, that's better than nothing. But there was a really interesting study on, the burden of disease and sort of, when you're trying to do cost effectiveness analysis, you have to weigh how bad is cancer versus a, hangnail. And, you have to really answer that question because like, okay, you've got limited healthcare resources and, how do you allocate them and do these calculations? And so you have to have a standard table of human misery and then, compare one thing to another. And the thing that was fascinating to me was when you quantify depression, in some of these studies, you get these answers from like asking people who've had both, like, would you trade this for that? And like how much suffering would you, how many days of this would you trade for how many days of, and so it's like all these really clever ways of trying to get at it. But at the end of the day, it's this sort of standard procedure. When you compare depression to like moderate depression, not even like the worst kind, moderate depression, a day of moderate depression is approximately as bad a day as the day you have a heart attack. Like the heart attack day has equal disability weight to like one regular old day of depression. And so like, we think about this with our treatment algorithms, like, oh, well, just try another medicine. It's like, okay, so the person is actively having a heart attack and comes to you saying like, I feel like I'm dying. I feel like an elephant is standing on my chest. Oh, here, try this for 2 months.
For 2 months, yeah.
It's like, No, it's an emergency. When somebody's having that much distress and that much pain, and obviously heart attacks and MIs will lead to actual death. And so, you want to stop that. And so there's, but it's because there is such a thing as interventional cardiology. There's something we can do about it. And so we do that. And so, yeah, I mean, I guess this, I think we're both interventional people. So like, we believe in this, but like our field's complacency with letting 5% of America walk around actively having heart attacks and say, oh, well, just try another medicine. It's probably not going to work for another year, 2, 3, 20. And like, yeah, that's just acceptable. It's like, versus like, I mean, ECT doesn't sound like fun, but like compared to that, like it's always a compared to what kind of a thing. And so
it's really interesting too, because it's something wrapped up in what the pathology of depression is, right? Like with depression, your ability to have executive function and plan and look to the future and say, okay, does it make sense for me to feel depressed and feel this way for another 6 weeks, versus the planning that is involved with ECT is definitely a little bit more than taking a pill once a day, right? And so people are like, oh my gosh, to think like I might need to take a month off of work. I can't do that. That's really too hard for me. But then to think, how much work have you really been able to do the past like 3 to 6 months while you've been depressed, and weighing that out and saying, maybe it does make sense to take a leave, do ECT, and after this month, I'm going to be able to go back full force and not feel depressed anymore. That level of planning and executive sometimes isn't there when we're depressed. And so it really takes your psychiatrist and sometimes family to help like think through that process of weighing out, wait, but like, is this path I'm choosing really the one that's going to land me where I want to be? Yeah,
no, I think that's exactly right. And as you said, it's as many different dimensions as we can hitting depression, because it is, again, I think this was interview I did with Charlie Nemiroff. He said that when we think about like cancer, it's like, do you ever just say, oh, I'm just going to do chemotherapy? No, it's like surgery, chemotherapy, radiation, like just hit it from every angle, and not just, one chemotherapy agent, but like 4 chemotherapy agents, because it's like, it's cancer, it's hard to treat. So, but again, with psychiatry, it's like, oh, well, let's just try therapy all by itself for 6 months. Let's just try one singular medication, and let's switch that out with another singular medication. It's like, you're a year in, like person's been suffering for you. So I guess, and so, that's
a great point too, that like often with ECT and with TMS, we encourage medications with both of those treatments, because the outcomes are a lot better when people stay on meds after those treatments in terms of maintaining their wellness after. So definitely hitting it from like as many angles as possible. They did a study where they will do cognitive behavioral therapy after ECT, and it was a really, really strong way of helping people not relapse after ECT and stay undepressed. So therapy, meds, interventions, I think all of these things together are really helpful in combination.
Yeah, that's something we've seen with with our clinic too, with TMS after TMS, and sometimes even like in the period of TMS. Maybe this is more rare when you're like not consolidating memories, but like with TMS in particular, you get these like, oh wow, now I get what my therapist was talking about, like the connection between the parts of the brain that the CBT works on. It's like, oh, it's actually plugged in now. Like you can do CBT in a way that felt impossible before. So
absolutely.
It's good to hear. I mean, I hadn't heard about that maintenance study. That sounds, it makes total sense that once the depressive, the ways that depression breaks your brain, if you can remove that, then, the therapy works now, or like therapy can consolidate some of this removal of the brain biology.
Yes, exactly. Totally.
And I guess that gets to this idea, and I think it's we easily dismiss it in psychiatry because, oh yes, that's just sort of folk opinion, but there's something deeply true because about some of these ideas of, if you would just exercise more as a depressed person, you'd get better, and I think that the part that's that's true about that is that, maybe that is true, but of course the person can't, or it's extremely difficult to even move sometimes. Psychomotor retardation is a symptom of depression. But I guess, some of the best psychological interventions are more or less encouragements in that direction, behavioral activation. It is, how do we get somebody moving in small ways and build up to bigger ways? But I guess, do you see these sort of, lifestyle interventions in conflict with, or how does ECT work in that constellation of, people who aren't exercising, who aren't eating right, who aren't doing the good things for their health? Is ECT, basically, I guess what I'm trying to say is ECT just the easy button for depression? Like, I don't want to do any of that work. I just want you to zap the depression away.
Yeah, that's a good question. I've really seen it work kind of, I don't know what the word is, but I think there's like a symbiosis essentially when people do ECT and then are able to be more behaviorally activated. So every time someone comes in for ECT, which is typically like 2 or 3 times a week for 4 weeks for like the acute phase where we're trying to. And so every time I see them when they come in, I check in like, what are you doing? Like, how are things going? What are you doing with your free time during the days you're not coming into ECT? And often in the beginning, people are like, well, I'm not doing anything. Like, I'm not able to do anything. Like, I'm laying on the couch. And totally makes sense, right? Like, people are depressed. They're coming in for ECT. Like, if they were able to get off the couch and able to exercise and do the things that everyone has been encouraging them to do, they would have tried that, right? They're not just coming in for ECT. I just decided to not try to exercise. We'll just come in and get anesthesia and have a seizure just for, because it's easier. Like, it's not easier. It's definitely not easier, but sometimes that's what it takes. And I keep checking in with people about that over those few weeks. And as they start to get ECT, oftentimes people will have more capacity to start to do those things. And so I'm checking in with them just like their therapist might have been checking in months ago, but they weren't able to get out and get up and get off the couch. And then they start to be able to do it. And with that ability comes, a little bit of an internal push to say, okay, I'm starting to feel like I can do it. I'm going to go take that walk with my dog today. And that push throughout the month, in addition to ECT, ends up working even better for people. So they have to create new habits around, how do I want to spend my days? Like, you can depressed, but if you're still sitting on the couch watching Netflix all day, for a while you might feel undepressed, and then that depression's going to come back because you haven't reintegrated the habits of things that are bringing you great joy in your life. And so as much as people can start to reintegrate those things as they get undepressed, they're forming the new habits and the new links in their brain saying, okay, I can do these things that are making me feel well, and they're propagating and continuing this pathway of what's going to help me.
Yeah, no, and I think this is one of the things that's just so interesting is like, we think about depression as like, oh, well, a person's just really, really sad. And okay, in some level of approximation, sure, that's not completely false. Of course, it does get to, well, it's not usually sadness by the time you get to severe depression. It's usually this like blackness or vacancy or no emotion or, void. But nonetheless, like, okay, so there's like a mood component, but then depression exists also in the body, there's inflammatory markers and things like that. But it also exists in the habits that even you develop habits to live a depressed life after being incapable of because of the other stuff doing anything else, and so you develop this these habits of going from your bed to the other side of your bed to terrible food because that's what's convenient and what you're craving, and and then then it's this feedback cycle. And so I think this is one of the things that's striking about depression treatments in general is that sometimes they're like opposed, or that you can push in either direction. Like, let's talk about your childhood trauma and like psychodynamic therapy. Yeah, that works. Let's talk about not that. Let's talk about the present only and ignore the past. The CBT, that works too. Like, don't worry. Like, what do you mean? Like, these are these are both opposite directions. Or like, let's increase the dopamine with the stimulant. Let's block the dopamine with the, antipsychotic. It's like, yeah, both those things work. Like, let's treat the right side. Let's treat the left side with you. Yeah, but both of them it's like, they're in this pit, and any direction is going to get out of the pit if you push them hard enough. And so, but again, like once you can't do much movement yourself once you're in the pit. And that's with all these interventional treatments. I think the thing that excites me is that you're rapidly able to get somebody out of the, give them freedom again, give them the ability to move. And then, like you said, build those habits, and those habits are going to be the thing that sustain them out of the pit.
Yeah, totally. Yeah, like continue your metaphor. It's kind of, if someone's in the pit, like it's helping them get up and out of it and on that edge there. And then it's up to them about which direction out from there they want to go. And, that pit is still right there. It's something they can fall back into without creating those new things that they want to do that are going to bring them meaning in their life. And whether it be work or family or exercise or socially, but going back to those same habits are going to lead back to the same place very frequently when people have like relapsing depression.
Yeah, and maybe that's one of the things that's most the image of ECT that's most wrong about Cuckoo's Nest. Again, one of just incredible movie, and I have a lot of admiration for the the filmmaking and the cinematography. Yeah, I mean it's a great film. But like I think the message that maybe is most wrong, at least when compared to modern versions of ECT, is that it's used as the ultimate symbol of control, of like lack of freedom, that the main character doesn't have freedom, and when he attempts to exert his freedom, ECT is used as this coercive means to limit his ability to choose. Whereas today, and with modern law that doesn't allow us to do that involuntarily, probably for the best, this is except under extreme circumstances, this is that it's a way for the typical person who doesn't have freedom to be sort of released from their depressive chains, to get out of the pit, to grant freedom. So it's almost the exact opposite image from that Jack Nicholson just very disturbing scene.
Yeah, I think that's a great way of putting it. And like you're saying, where depression, like in one way can feel like sadness, but in other ways can feel like a void or a blackness, or like just a complete disinterest in anything about life. And then regaining that ability, interest, is amazing and magical. And then to have the opportunity and the freedom to say, oh, well, now I have this interest, like where is it going to land? Like what am I interested in? What do I want to do? And to have that freedom again. Like I spend so much time talking with patients about that. Like, wow, like now that you feel like you want to do things, like what do you want to do? Like the world is your oyster. Like, are there hobbies you used to have, or the hobbies you want to have? Like, what would you like? And having that freedom again to pick those things is cool.
Yeah, no, again, I think it's a wonderful thing to sort of do almost palliative care in psychiatry and prescribe the medication, figure out what the best medication number 43 is. But being able to have those conversations of, what do you want to do with your life now that you have it, is just so much fun. And that's why I love TMS, is it works. And so, and again, like there is, it's almost like, this new breed of psychiatrists that's, more like surgeons, where you get this sort of fix from like, oh my gosh, it worked again. Like, rather than, and okay, maybe it's a little immature. Maybe we should be appreciating all the other aspects of, the goodness and the depth of suffering, and that's all good, and we get that too. But it worked. So exciting.
Like we get to help people get well. Well, that's why does everyone want to be a doctor? It's like for feelings like that. It's really cool. Yeah.
Okay. So the other question, and I think this is with new treatments and then maybe ketamine in particular, but one of the questions that comes up with all of these treatments is, okay, great, you can pop somebody out of their their depressive state and they're all better for a week. Does ECT stick? Does it last?
Yeah, great question. There have been a number of studies about what to do about that. 50 or 60% of people will get undepressed, say around after a month of ECT, where they're getting it 2 or 3 times a week. And then what? And if someone does nothing, so someone stops ECT, takes no medications, does no therapy, their likelihood of getting depressed again is quite high, like maybe 80 or 90% in the next year. So we definitely say, like, do not do nothing after you get ECT. Like, you've been depressed before. Someone hasn't just been depressed for a couple weeks and they're getting ECT. Like, this has been a long-standing illness for them. Like, you got to do something, like getting physical therapy after you've had a surgery, right? You've got to do something to help work that muscle, help stay well. So there are different options of things that help people stay well. One option is to do ECT at a much more spaced out interval. And so that's called continuation ECT for the first 6 months or so, where people will do once a week, and then they'll do it every other week, and then space it out to once a month. And that does well with helping people stay well. If you combine that with medications, that helps people stay well even more so. So if they were on an antidepressant, staying on that antidepressant, adding on lithium is even more helpful. So doing meds and lithium is about as equivalent to doing other meds plus ECT. So that's another mechanism. People have started looking into if you could use TMS as a maintenance strategy after ECT. I think that's a possibility. It's just insurance companies rarely cover something like that. So there haven't been a lot of studies looking at it. But I think that's something that could potentially help in the future. Or like I was saying, there was that study with CBT, and doing CBT after ECT was really helpful at helping people stay well.
So if somebody does all those things and engages in all those things, you're one of the fortunate 50%, you feel better. How many people, in the best case, are feeling better 1 year after ECT?
If someone does all of those things, it depends on the person and how many times they've been depressed before that and how long they were depressed before they got undepressed. So like barring those factors, it's probably between like 50 to 80% of people won't have gotten depressed that first year.
And if they do, does retreatment work?
Yeah, it often works for people. Yeah. I would say the vast majority of people, if they've gotten undepressed once with ECT, will get undepressed again.
It sounds like a pretty good treatment.
Yeah.
Maybe somebody should think about becoming a doctor and, doing this.
I encourage anyone listening to this who wants to become a doctor and do ECT to come talk to me. I encourage you.
Yeah, no, I think, and you'd mentioned TMS and some of the other ways to make it, medications and therapy and all these things to make it stick. I think that does make a lot of sense. And just like anything, maintaining something, it's not just the biological. And I think that's one of the other errors of our field over the past 50 or 100 years. Is like, it was sort of this pendulum swinging to like, oh well, it's all the subconscious. And it's like, maybe that's a part. And then it's like, oh no, forget about all that, your mother stuff. It's all the biology. And so here's some pills. And it's like, okay, gosh, you guys, like seriously, is this what we, yeah. So, I don't know. And maybe we'll realize that our perspective right now of, we need all these things together is misguided somehow in 100 years. But nonetheless, it seems very plausible to us now. And I think we've seen a lot. I think both of us have seen a lot of people get better and stay better with this sort of combined approach.
Yeah, I kind of think of it as if, say, I've never really been a runner in my life, but say I decide I want to learn to run a 10K, and I'm going to run this 10K in 6 months. And I run the 10K and it's great. And then for a year after that, I don't run at all. I'm not going to be able to run a second. And if I hadn't been periodically doing some running, working out throughout time, I'm going to lose all those muscles that I've regained. And it's kind of like that. I think if you're not doing things to help maintain the gains that you've gotten, you're going to go back to where you were at some point. If that's if my natural state's not being a runner, I'm not going to like magically be able to run whenever I want to.
Yeah, no, I think that's a good word. Any final thoughts, or somebody thinking about getting ECT, who's been depressed a while, tried a bunch of stuff. Any closing thoughts to the hypothetical or real patient thinking about ECT right now?
That's a good question. I would just encourage you to really seek out a psychiatrist who's educated in ECT. I think, like even within psychiatry education, I work really hard to help residents to learn about ECT and TMS, but not everybody really has learned about it in residency, and so not every psychiatrist, not every therapist will really be able to talk to you about it and see if it's a good fit for you. So seek out someone who you really feel like knows what they're talking about, can explain it to you, can answer your questions, can refer you to a place where you feel comfortable. Yeah, I think having someone who's like can help you with that is really useful.
Yeah. Well, thank you so much for joining me, and it's always a pleasure and joy to talk with you.
Yeah, thank you for the opportunity to talk with you and everyone else about this. Thanks.
Absolutely. Okay.